Good afternoon, everyone. My name is Cynthia Kelly. I'm the Executive Director at the Gluten Intolerance Group. I'd like to welcome you to GIG's mini webinar series on skin clues for celiac disease. These sessions are being recorded and will be available at the conclusion of the series. If you have any questions, please put them in the Q&A content at the bottom of the link at the bottom of your screen. We'll be answering questions at the end of the webinar today, and those that we don't get to, we will get to tomorrow. Dr. Gretchen Kreizenbeck has a lot of information to cover, so let's jump right in. Gretchen?
Hello, everyone. I'm excited to be here with you today. Thanks for joining us. I'll try to stick as close as I can to the 30 minutes, but it will be recorded and we might bump over to 35. So you can always jump back in later if you miss just a couple of things at the end. And please join us tomorrow as well. So I'm going to tell you what I've learned over 14 years of practicing dermatology as a board certified dermatologist. I have no financial disclosures today. And we're going to go through several cases. So individual patients, some are a few amalgamations, a few different pictures of several cases that I have had who have looked very similar. At the end, we'll go through how do we actually diagnose these patients. Of course, it's a little bit art of medicine and pattern recognition that we'll go through. You're going to be experts by the end of these 2 days. But then how do we actually interpret these blood tests or send them to a gastrointestinal physician to obtain the gold standard test of endoscopy with biopsies? In medical studies, they actually did 6 biopsies of the small intestine to confirm celiac disease in many patients. But we can't always get to that. So day 2, again, we're going to go through a few more patients, treatment, and follow-up, just because this condition can affect so many different organ systems. I'm going to back up and give you just a little background about celiac. I'm sure most of you know that it is an autoimmune condition that affects 1% of the population. In fact, many studies point out that it's probably underdiagnosed. By some studies, they say 30%. In an Italian study with 17,000 students, they actually found that it was undiagnosed in 80% of those students, many of whom were asymptomatic, not having any symptoms at all. Jumping into, however, my presentation, what we find often is that there can be young people, all ages. We're taught in medical school how celiac disease is often noticed by short stature, so failure to thrive in infants where they're not growing, they're not gaining weight. But unfortunately, celiac has over 300 symptoms. And as we get older and as some patients with celiac grow to be quite tall, in fact, and some actually can be overweight and have, like I said, no symptoms, various symptoms that are unrelated to even the gut. So we really have to have our eyes wide open and be aware that celiac can look like many, many different things. So my first patient is a 19-year-old female college student who presented to me because she had was losing very rapidly large patches of hair. So this is her, and if you were a young lady off in college by yourself in another state, you would be very upset as well. You can see here the tissue sign, the Kleenex sign. These are patients where there are often tears during the visit, and it often lasts well above that 10 to 15 minutes that are often slated. She had multiple areas of, again, clear patches of hair loss. This is actually just a little pigment she put in to hide the hair loss, just an additive. If you get really close, dermatology-wise, she did not have any additional scale, so there were no signs of infection, no pustules, not thinking about ringworm and other things. You could still see the follicles, so it was non-scarring. There's hope that this hair can regrow. But again, she had multiple significant patches of this condition that we call alopecia areata. As you can see here, this is a different patient, but again, similar story, who was kind enough to go back and give me some of her pictures as well when she was a young woman and presented in the very same way. This 19-year-old that I met had chronic anxiety, otherwise a pretty healthy lady. In fact, really didn't, admit to any other health conditions. When I really kind of started asking her, well, do you get stomach pains once in a while? Do you have diarrhea sometimes? Did you get food poisoning as a young kid? It did turn out that, her mom's with her during the appointment. Often families are affected. And mom kind of pointed out that, oh yeah, we had taken her to a pediatric specialist, GI specialist who actually had done an endoscopy on her as a child. And I find that this can sometimes or often be the case where these patients come in already having had a normal endoscopy, which again, it can be or is the best test that we're aware of at this point for celiac disease. Many of these patients come in also with this iron deficiency, malabsorption, which we'll get into a little bit later. They often admit to, a little fatigue. They don't really come in, saying that's why they're there. We all think we're going through stress or a little tired due to other things, but these patients are exhausted, sometimes taking extra naps. Again, some of the patients can even have some nausea, vomiting, diarrhea. This patient was actually starting to have almost daily vomiting, almost to the point where I was concerned that maybe this was more of a anorexia or bulimia or another kind of eating disorder. She also denied drugs, no marijuana. Again, we really have to think about all the reasons that we can have GI and loss of hair, lots of reasons. Many of these patients are on gastrointestinal medicines, again, trying to help her with the vomiting. They often can be on some of these muscle relaxants as well, since there can be kind of chronic pain. She did have a positive ANA, but no other stigmata of lupus or other autoimmune disease. But again, kind of, honing us in a little bit sometimes that something autoimmune is going on. When I met her, she had a transglutaminase. It may have just been an IgA. It was negative, so again, unrevealing. Extensive other tests, again, over the years, as well as just in that last year that she had started losing hair, which were all unrevealing. I ordered more tests. I find a lot of these patients who are losing hair, either in patches or just diffusely, often end up having malabsorption, low vitamin D, again, lots of reasons to lose the hair. But this 19-year-old patient, again, this is a different patient here, but all the same type of hair loss. This 19-year-old actually had scurvy. She had low vitamin C, which is a first diagnosis for me. Again, eating a regular American diet, talking with family, no anorexia, nothing else going on, even though, of course, we have to think about food restriction and make sure they're getting all of these important nutrients in their system. She had other vitamin deficits. B12 is the other important one that we typically look for because that's absorbed in that very specific part of the small intestine, the duodenum, where celiac disease affects the villi, where there's blunting, where we then can no longer absorb that B12. So I commonly will check for B12, which can be low in lots of people for lots of different reasons. But when we find it's below 400, that's actually abnormal in my book, even though Quest and other labs sometimes say it has to be below 200. People start to lose their hair and feel exhausted and get irritable and other symptoms when it drops below 400. Her other values were low, but low normal. And in fact, the gliadin test that I also like to order blood work wise were officially negative. There was a teeny little bump in the gliadin IgA. We'll get to that a little bit later on, how I find sometimes that is helpful to suggest a diagnosis of gluten sensitivity on this spectrum. Again, not officially diagnosing celiac disease, but when patients are either first getting sick or before they've really fully developed strong antibodies or serious gut damage, sometimes we just have these little hints, and unfortunately, evidence-based medicine is not always perfect. So sometimes we have to take these hints. So I actually referred her back to GI. I asked them to get another endoscopy. Of course, she was in college. She was busy. They tried some other medications. Her second endoscopy was unrevealing. Of course, I didn't see the actual pathology results, but according to, the read by the pathologist, they really didn't see much. But this is, again, where we kind of have to step back and look at the bigger picture. So malabsorption, multiple vitamin deficiencies. Of course, we try to supplement those. We fix those. Her levels did start to go up, of course, rather slow. This is when sometimes, those IV supplementations or, again, kind of those banana bags and other, treatments that we can give in the hospital can be helpful. But these are usually outpatients. We did do additional testing like we talked about. Again, nothing official for celiac, but there is this little hint here. Endometrial antibody is a very specific test for celiac disease. When that's positive, it's very indicative of celiac, but I rarely find that it is positive, and it's a very expensive test. So we step back. Again, this is about pattern recognition. Fortunately, she did have some GI symptoms. She had malabsorption. She had significant hair loss. We had used all the typical treatments. In fact, she had seen another dermatologist and several other doctors before she met me. At that time, she had tried all the typical treatments of injection steroids, oral steroids. Those are all the typical treatments for alopecia areata, this autoimmune hair loss or skin condition. Currently, one of the best treatments that still is only 40% effective for alopecia areata is this baricitinib. It's a JAK inhibitor that many of us use for different autoimmune conditions. Comes with a large risk of side effects. It's a big time medicine, but still safer than many of the other immunosuppressants that we would often put patients on, even prednisone, things like that. She was desperate to try anything. So as you can see up here, I did start to talk to her and the family about this possibility of a trial of a gluten-free diet. Typically, I recommend 2 to 3 months. What happens though is, this is a kid at college. She's eating in a dining hall. It's difficult anyway to, avoid or kind of make certain requests in a dining hall. And so I don't think she had great compliance at first. And again, she wasn't really buying into this possibility as well. So continued to rapidly lose hair. We put her on this medicine, doesn't work half the time, over half the time. Fortunately, it did help her. But again, at the same time, we were getting her on this trying for 100% gluten-free diet. Happily, she did have hair regrowth very quickly, which again is an amazing response to this medication or possibly the gluten-free diet. Like I had described before, all of these other medicines that often can work were completely ineffective. So she had recalcitrant, again, at first, no response to the typical treatments. Again, these JAK inhibitors have helped a lot of people in the last couple of years. Eventually, she did finally go to that 100%, excuse the error there, 100% gluten-free diet. All of her vitamin deficiencies reversed and all of her hair was regrown. So in these situations where patients are taking these strong medicines, that baricitinib or other JAK inhibitors, when they stop those medicines, their hair often falls out, like almost 100% of the time. And so for the pharmaceutical companies, those medicines are incredible. They make lots of money, okay? But for the rest of us being on a chronic long-term immunosuppressant that actually has heart attack, MI, stroke risk as well, for a young 19-year-old and others, we don't want to be on that forever. I was quite positive this patient, I know she has gluten sensitivity. I'm quite concerned about early celiac as well, even though we couldn't quite prove it. So eventually we did stop the baricitinib. And in fact, just last month, I reached out to her. She's been off of that for over a year. She has had 0 further hair loss. And in fact, her gut symptoms, that daily vomiting that, again, we could not fix with other pharmaceuticals, we finally resolved that. She's kind of back to her regular functional life. So this is her from just last month when I reached out to her again to send pictures for this talk. And look at how beautiful, not a single follicle that's missing. So she did very, very well. We grew all of her hair, again, non-scarring, really wonderful case. Okay. We're going to jump ahead to case 2. So this is a 45-year-old female who I met at the time because she was having severe itch. Now, a lot of these patients are really itchy across the posterior scalp, but it can be head, neck, lower back, but kind of arms and legs. Typically it's supposed to be elbows and knees, but really they're often just itchy all over. Of course, I have to do my usual workup. Itch can be a long visit, lots of labs and tests, even thinking about scabies. We think about new detergents. Again, this isn't a dermatology talk, but we do all the usual things. She really didn't have much of a primary rash because we do think about eczema. We do think about primary skin conditions. When I got really picky, she did have a couple bumps, couple papules that maybe could have been little blisters or vesicles that had been scratched off, but really didn't have much on the skin. Basic blood work was normal. We started her on gentle skincare treatment and, of course, gave her some standard treatments, topical steroids, oral antihistamines, sometimes even oral prednisone, systemic steroids. So a lot of the times we try to titrate up, really kind of get them better, which works really 98 to 99% of the time for most people, okay? She was otherwise healthy. She did not say she had, even when I asked multiple times, really wasn't having other stomach issues, maybe headaches, but she was a really healthy lady. But again, we kind of gave her typical treatments and she was not getting better. I ramped up to class 1 topical steroids, those clobetasol and stronger medicines, and still wasn't getting better, even oral prednisone. I get pretty tough with these patients about avoiding other products. Again, topical allergies can sometimes do this, but eventually, thinking about her again, I had to come think about this skin condition that I think we often miss because it does not always present itself perfectly, like this picture. So this is off of a lovely website, a group out of New Zealand, a dermatology group that has a lot of wonderful, if you have skin questions, I'll refer to them at the end again, but a lot of great pictures for all of these skin conditions. So this is a patient, I'll get into the actual workup, that I really think she did have a version of Dermatitis Herpetiformis. Typically, we can prove this with a skin biopsy, but in this patient, I didn't quite get there. I'll go through that in just a minute. But to review Dermatitis Herpetiformis, this is actually a non-contagious, so it has nothing to do with herpes. It's, again, an immune-mediated, very, very itchy rash that can look like anything. Okay, so yes, classically in my textbook, they tell us that it is grouped or herpetiform. That's kind of where the name comes from. Individual vesicles, sort of like bullae that are smaller. So fluid-filled bumps that are usually collecting on the elbows, knees, scalp, lower buttock. But again, I've seen many, many different patterns of this. In fact, I had a patient who, again, had all the positive everything, including this positive DIF biopsy that we'll get into in a minute. So here are the typical tests. In fact, if you do get a positive DIF, so direct immunofluorescence, that's what this stands for. It's a different staining instead of the typical H&E staining underneath the microscope. That actually is enough to diagnose celiac disease. So we as dermatologists do diagnose celiac disease when we see these classic pictures of Dermatitis Herpetiformis. Really easy when we get a biopsy, or in fact, we typically do these 2 biopsies, a standard biopsy and then this DIF biopsy. And then sometimes blood work that, again, we can get into. Unfortunately, either my sampling of where I took the biopsy, that can play a role. But again, like I find many times with some of these patients, we do not get a positive result on these lovely tests. I then tested her genetics because we do understand that the HLA type, so specifically DQ2, which 30% of the population carries. So that doesn't mean 30% of us have celiac. We know, again, about 1% or more of the population has celiac. But then there's also this DQ2 that if you have that, you have actually a 14 times higher risk of becoming a celiac in your lifetime. And if you have both, you're very high risk. Okay. So sometimes we can sort of rule out celiac disease, or again, kind of say it's really unlikely because your genetics, don't fit with that. Again, sometimes classically we think of the, lighter skinned European ancestry as being this celiac population. Again, a lot of Italian studies, a lot of European studies. But it's kind of interesting. Celiac, actually, the highest incidence is 5% in sub-Saharan Africa. Okay. So actually, dark-skinned individuals have even a higher incidence of celiac in other areas. It's also quite common in North Africa, the Middle East, and India. Okay, so again, this is very specific to this HLA typing where many of us still can be at risk for celiac depending upon our genetics. So in dermatology, we are taught to treat them with a 100% gluten-free diet, but often these patients still need dapsone. So this patient, I kind of offered these different treatment options. She was very motivated, like many of my patients are, and she wanted to try that 100% gluten-free diet. Her itch melted away immediately. Again, it was just a switch that, turns on, turns off. Sometimes these patients get glutened accidentally, or again, sometimes they test it themselves or, cheat, and they really find that itch kind of returns just a light bulb. It snaps right back in. Takes a little while sometimes to turn off. It doesn't turn off as quickly. But they really kind of, the itch is often pretty connected to gluten. Another case, 56-year-old female nurse, this was actually during COVID about 5 years ago, came in with slightly itchy but round, very well demarcated, scaly red to pink, but plaques that have this white kind of micaceous scale on the mostly palms and soles of her hands, but sometimes we'll see these patches on elbows and knees, scalp, ears, not always the face, but really could be anywhere on the body. She had tried an over-the-counter antifungal cream, again, thinking about ringworm, which was smart, but this was classic psoriasis. Okay, so here is one of my patients. This again is an official picture from that same New Zealand derm group that I shared with you. Really classic appearance for well-established psoriasis. These patients, again, often a history, and it was COVID with depression, anxiety. She did admit fatigue, some joint swelling, stiffness. Again, you can have psoriatic arthritis with the condition, with psoriasis. So we do think about arthritis in these patients. She declined blood work. Again, kind of, I always have to think outside the box about all these different things that can affect these patients. But of course, I'm going to offer good treatments to them. So I did offer biologics, topicals as well, but a lot of those biologic immunosuppressant medications can suppress the immune system. And so this nurse working in the hospital during COVID didn't want anything to do with that, which made perfect sense. And so she was really motivated to try some other things. In fact, there's a lot of much literature out there that really talks about how psoriatic arthritis and even some skin psoriasis can be connected to celiac disease, and how we really need to look for one or the other when we're diagnosing each. This patient, again, her stiffness, joint pains lessened. So again, often these patients do have positive blood tests. A lot of times they can have these positive anti-gliadin antibody. That's what's tested in some of these, again, 3-month gluten-free trial diets. So again, a lot of these patients, I find their skin gets better. Sometimes it gets totally better and they don't need me for any prescriptions. They come back years later. So this is actually that same patient who had that huge plaque on her back. This is leg psoriasis that is now resolved. This is just that little bit of pinkness that remains once that scaling and plaque thin out and resolve. But she was so motivated to try a gluten-free diet. This is after several years she was clear over these extensive areas that'll eventually repigment, but that's actually clear from her gluten-free diet. This next patient was a 64-year-old female who came in just, asymptomatic, but just had redness, bumps, patches of red on her face, sensitive skin. A lot of patients I see like this, sometimes just during a skin check. So kind of mild, but when we get close, we see fine little telangiectasias. Sometimes they have acne-like bumps that can bother them. Again, kind of typical past medical history, maybe some stomach pain, acid reflux. She did admit to some diarrhea, some stomach aches, sensitive stomach. So sometimes these patients, kind of say, oh, I have IBS, or, kind of some other things going on, or they're on, the typical famotidine, acid reflux medicines. Often they are taking, again, different pain medicines over the counter, different varieties for these aches and pains. So when we really got into it, she was really having quite a few symptoms, severe abdominal cramping at times. Sometimes this is just one, segment of their life, goes away forever. A lot of these patients can have severe distension, bloating, gas. Those are some typical celiac signs as well. So this skin condition is rosacea. This is, again, common in America. Not everyone with rosacea has celiac or gluten intolerance, but many of these patients do have a gut condition of some kind, and it is well known, again, in the rosacea literature, that celiacs commonly will develop a rosacea, or again, vice versa. When I have patients who come in with this type of severe rosacea or recalcitrant to treatment rosacea, we really have to think about celiac. So this one was a home dunk. We just ordered some blood work. Transglutaminase was blazingly positive. This deserves a phone call from the doctor, from the primary provider saying, hey, this really looks like celiac disease. This means 100% gluten-free diet for the rest of your life. So this is a significant diagnosis to give someone, changes their lives, I think saves lives, and can really just give them excellent health when we can fix this and make them better. But it's still pretty monumental to tell them what they have to eat or avoid eating for the rest of their lives. So of course, I also treat these patients with typical dermatology topical treatments, sometimes even oral antibiotics. But again, this patient was very motivated. And we know that not every single symptom is going to be related to celiac disease, but we know that these patients are going to feel a lot better, and often the treatments that do work for most of us will then work for them. So that's, again, this pattern that I want you to recognize is bad skin disease that does not get better with typical treatments. And then again, there are these very specific types of skin disease that I see often with celiacs. Unfortunately, she did later develop a separate autoimmune condition, rheumatoid arthritis, that again can be seen with celiac. We do see that the later these patients are diagnosed, the more the additional higher the number of autoimmune conditions that they have, which we can't always turn off. So that's kind of that study proving it, where again, if it's that kid who's not growing or the infant who's not, gaining weight, easier diagnosis with blood work, sometimes endoscopy when they're positive. But most of my patients are over 20, even though I do have some kids. Unfortunately, they then have these permanent autoimmune conditions. So when do we test? Okay. Because, we know that everything costs money. We know that, then we have to follow up these blood tests. That's also something to think about. We want to be smart about what we choose to do and what we put patients through. Endoscopy has a cost as well as it's a medical procedure. So I'm joking a little bit, saying all the time, but you really kind of have to think about celiac almost all the time, otherwise you will miss it. And so that's really my point down here. You have to have a high index of suspicion. You have to think about it, put it on your differential. There's always a differential. One of my best teachers in residency taught me that, Jean Bologna. Otherwise you will miss it. All right. So when do we accept that blood work? Because again, many of those patients did have a negative endoscopy or negative blood test at a certain point. When do you accept that as, oh, that rules out celiac disease? They do not have celiac. Well, sorry to share it with you, but never. A lot of these patients, we're going to go through 2 more cases tomorrow. Unfortunately, even multiple patients where they have had endoscopies where it can be missed. So now we're going to go through just a couple of fine things at the end, kind of closing out in the next 5 to 8 minutes. I could have given you so many other pictures and other cases of patients with chicken skin or keratosis pilaris. Those are kind of those firm, reddish, pink bumps, or strawberry skin, I think got popular on TikTok. A lot of us can have that with eczema, or again, just kind of having dry skin. Sometimes that's a separate genetic population. But again, it's the bad cases. It's the cases where it's on the belly, it's extending down to the lower leg or the forearm or across even the face. Bad keratosis pilaris. That's when we kind of go, there's some malabsorption. It could actually be a sign of vitamin A deficiency. I have many cases of, again, to be confirmed celiac disease where they're experiencing telogen effluvium. So that's just generalized thinning of the hair. Again, non-scarring. So that means it will come back, but it does take kind of 6 months to recycle typically. That's what we see after pregnancy, where a lot of us shed that extra hair that we kind of hung on to during pregnancy. And again, that's often associated with many of these vitamin deficiencies. Some patients have acne. Again, boring old basic acne that a lot of us have anyway, but acne that doesn't get better or that is just so terrible. Hives are a common and sometimes a chronic problem that again can suggest celiac. Angular cheilitis is where, or perleche is where you have kind of scaling, flaking, and, redness, pinkness, kind of a rash on the corners of the mouth. Again, often tied to either low B2, riboflavin deficiency. Sometimes even zinc can do that. Low zinc can give you a much worse rash kind of on face and butt. Again, even just being prone to infections. Again, kind of a lower immune status, sometimes from that malabsorption and low vitamin D, low zinc. Oral ulcers, especially unexplained oral ulcers. So again, sometimes herpes infection, but often a deficiency of B12 can give patients this. Frequent cold sores, frequent cavities. Again, that's, I guess, not quite dermatology, but tooth. We do look inside the mouth, but that would be more dental. And then again, really just common stuff. We went through itch, but sometimes it is just eczema. It is truly just classic atopic dermatitis, dry skin, and again, this keratosis pilaris, really kind of non-specific stuff, but we just kind of have to think about it when these patients aren't getting better or they have multiple other things going on in their life that suggest it. So multiple studies show that many celiacs have no symptoms. It's commonly 30% of celiacs quoted that have 0 symptoms. I see a lot of folks who come in already knowing they're iron deficient, sometimes anemic, but usually just a little low in iron. Their blood count is actually normal. So ferritin is the test to look for. Again, I like to look for a little bit of a higher ferritin because we do start to have symptoms and again, hair loss when it drops below that magic number. These patients often don't really describe diarrhea, but they have frequent, sometimes explosive, loose or watery, or, sorry to kind of get gross, but kind of goes all over the toilet kind of bowel movements. So normal to them, but they don't always recognize that as diarrhea or a problem. I had one patient who was having hair loss, but she had unexplained weight loss. So besides cancer and thinking about B symptoms, celiac can do that in adults besides kids. Of course, abdominal pain, gastrointestinal symptoms, but just overall autoimmune, feeling yucky, feeling exhausted, fatigue sort of symptoms. But again, this can look like anything. Patients can have constipation. They can go back and forth, diarrhea to constipation to all sorts of things. But I like to ask about family history. Again, sometimes there's a suggestion of IBS or they're on medications that help with stomach, help with acid. And then we think about, again, screening relatives if we don't already know that the relatives have these different conditions. So I know I'm preaching to the choir, but we all know that, we're rushed in clinic. We're trying to see as many patients, help as many patients as we can and press for time. Patients don't always bring up these different things because they don't want to complain, or they go, hey, I'm seeing the skin doctor. I don't need to talk about my diarrhea. It's embarrassing. The farting and flatulence and, again, all of these things that some of those patients really have, they don't want to talk about, they're embarrassed, or they don't seek someone because they think, oh, everybody has that, that's not important. So we're just running out of time. I just want to go through, I did promise, how to diagnose. This is the screenshot that you should take. And then there's one more and just a couple slides. So the best test is endoscopy, but in my personal experience, I know over 5 patients where it's been missed. Okay, so again, that's specifically going in looking for celiac where either the wrong area is biopsied. This is a patchy disease that, again, we could talk for over an hour about how we have to sample the right area. I did admit, as a dermatologist, sometimes, our biopsies are not correct because of improper sampling. Patchy disease, the staining has to be perfect. When they look at the villi, they really have to kind of go, oh, are they shrunk a little bit? Are they flattened a little bit? Is the staining a little bit paler? And again, if they just don't quite see, a little bit of what they're looking for, they will not classify this patient as having celiac. And then the other resounding point here is that these patients have to be eating gluten. Often they're told to do a gluten challenge before they get their endoscopy. So eating 1 to 4 pieces of bread, depending upon what study you read, for almost 12 weeks. So 4 to 6 weeks for some, but 12 weeks is kind of the old literature before they get these blood tests or endoscopy or both. So again, if they're already avoiding gluten, these will not be positive. These are the good blood tests to do. Again, endometrial is rather expensive. It actually uses monkey esophagus. So for now, we're still able to get that test, but I do find it's not always that helpful, but these top 2 are the best ones to order. And then we really need that total IgA. This goes into that genetic testing that I was telling you about. You can order this as well. I'm not plugging Quest, but again, a lot of us, I'm a private practitioner, so I like to know what test do I need to actually order when I send the patient out. So again, it's very, very common for patients to carry either the DQ2 or DQ8. Does not prove that you have celiac disease, but it's highly suggestive that it is a possibility and certainly could be what's going on. This is the screenshot I want you to take. So this is my favorite test. Celiac disease diagnostic panel. I think the transglutaminase is very important. They actually just completed a study in 2025 looking at diabetic kids with type 1 diabetes. When they lowered that threshold, so instead of looking for transglutaminase that's 11 times normal, they just lowered it to 6 times normal. And guess what? They found more celiac disease. So again, in those patients where there's that little bump of the gliadin or little bump of that transglutaminase and it's not clearly positive, well, think about it. Maybe they're just starting to make antibodies and maybe they're not in that full spectrum of full-on celiac disease, but one day they might get there, okay? All right, so we have to eat gluten to have those tests be accurate. This just talks about how anti-gliadin is very useful as well. Again, when we just did the really cheap test, transglutaminase, in this study, 19% of, again, classic biopsy-confirmed full-on celiac disease patients would have been missed. Okay, so quite a few. This is the test I do not recommend because, again, you're going to miss those with that gliadin test. So don't look at that so much. I know we're out of time. So, again, just looking through a few of those signs and symptoms, again, mostly non-specific. At the end of this, I just do want to say, what do you do when all the tests are negative? You talk to the patient. You say, hey, you can try a 2 to 3 trial a month of gluten-free, 100% gluten-free diet. That's hard. They have to read books. They have to check websites. I'll give you all that information here at the end. I usually send them to the library. I tell them to think about it, put it on their schedule, maybe after the holidays, kind of really plan for it. It's not something just to start tomorrow or later today. It is something to really think about. Again, this is that spectrum where, at first we might not be able to test and see that positivity, but eventually we can diagnose celiac. But I do like to have the patients think about it and try it on their own, because what happens is, yes, there's a nice, when you have a positive test saying you have celiac, that's more incentive to stay gluten-free for the rest of your life. That is very, very important. However, we don't always find that they're positive. And so when patients go on this 100% gluten-free diet, within days to a week, they often feel like a different person. So this is the challenge, is to stay that way. Again, many of my patients with skin symptoms and itch, that itch comes right back, or, hair loss comes back when they start eating gluten. But tomorrow we'll talk more about why it's so important for overall health, cancer, again, those other autoimmune conditions that we can develop. Just having celiac and still getting gluten in our diet, which is the cause or part of the cause of that cascade of the immune system getting confused, turning on celiac in 1% of the population, but again, underdiagnosed. So already kind of alluded to this. Again, tomorrow we'll talk a little bit more in depth. Try not to overwhelm your patients too much. Again, today I just gave you lots of information, but just keep in mind patients can be overwhelmed, even though this is absolutely life-saving for so many and changes their lives in a really wonderful, positive, good way. Just kind of, I like to plant seeds. I like to, give them say, well, in some people, here's kind of a list of things they feel. You can check this website. Let's talk a little bit more next time. We don't always order all the tests right away. But I think talking about it, kind of opens them up to reading about it and understanding about it, because they really have to understand what's going on, and they're the ones who have to eat 100% gluten-free. But again, you can see here that so many people get better. These are all of my references. Again, this will all be recorded and online. And these are the good websites that I was referring to. Down here, we have more of the dermatology-specific, generalized websites, less about gluten and celiac. But again, up here, these are the great websites that I refer my patients to on how to eat gluten-free. Again, that's a separate hour-long lecture, and some other intricacies. So on that, I will pause. I was a little over 30 minutes. I apologize. I wish you all a great day, and you can stick around for questions if you want.
Thank you. We will take questions now for a few minutes. And again, this is being recorded. If you have questions that don't get answered today, we will address them tomorrow. Taylor, can you help us with any questions?
I can, yeah. Dr. Kreizenbeck, we have one comment here. An anonymous attendee says, I have celiac and other autoimmunities. I have a great deal of hair loss. I am very careful about diet, and my tests for compliance are always perfect.
So I guess a comment wasn't a question. Was that it?
Yeah, it appears to be a comment, but I just wanted to make sure to share it with you.
Yeah. Thank you for sharing, whoever submitted that. I'm glad that the other vitamin levels have been checked. Again, I shared several that should be checked. Now dermatologists do have that other medication out there that sometimes we can get the hair to regrow. But unfortunately, that's kind of exactly the point of me giving these lectures and sharing this last slide with you, is that the older we are at diagnosis, and again, many of us are diagnosed in adulthood, we have these other autoimmune conditions. And so again, you're not my patient, so I'm not sure what type of hair loss you have. Tomorrow, I will go through more severe alopecia areata cases where it is complete hair loss, alopecia totalis and alopecia universalis, where we've lost eyebrows and eyelashes, as well as even body hair. And that often does not come back when we've had celiac for a long, long time, even when we're perfect about eating gluten-free. Like I alluded to tomorrow, there are really important health reasons to eat gluten-free, not only to feel better, but unfortunately, you are right that the hair does not always completely regrow.
Okay, we've got two more comments here. We've got Virginia Morgan. How do we access the recording since I had to join late? I believe it'll be sent out to you after it processes and when this meeting closes. And then we have Nadine. This was one of the very best and comprehensive talks on dermatology and celiac disease and gluten-related disorders. High praise. Thank you, Nadine.
Thank you. That's very kind.
Okay, and we have one more comment that just came in regarding risk of second autoimmune condition. This data is for all celiacs, regardless of age, when first becoming gluten intolerant. And that's a question.
Raise it again.
It says regarding risk of second autoimmune condition.
Yep, so that's this slide.
Is this data for all celiacs, regardless of age, when first becoming gluten intolerant?
So that's how I understood it. Again, it came from this website. So maybe if you jump into that, they could give you more specifics. Again, that's not my individual study. It was just one of the articles that I read in preparation for this. Tomorrow, again, I'll get into more risk of non-Hodgkin's lymphoma and even gut lymphoma, again, in a very small subset of celiacs. But the point of that talk, and again, even this talk, is that the earlier you are on a gluten-free diet, the less chance you have to develop a permanent, or maybe not permanent, but a separately treatable. But again, once that kind of starts up, not always controlled just by eating gluten-free. So what this table is, how I interpret it, how I see it, is that the earlier we start eating at best we can, 100% gluten-free diet, the lower the chance is to develop other autoimmune conditions. I did share with you that, 60-year-old who may have already had a little rheumatoid arthritis brewing, or, again, shortly after she went gluten-free, I think it was within the first couple years, was ultimately diagnosed with rheumatoid arthritis, another autoimmune condition, and rosacea is an autoimmune condition. So, life is life. We're going to get different things. And yes, a lot of it can be connected to celiac. But the point of this is the earlier and the better we are about going 100% gluten-free, and the more information we can share with patients about getting this diagnosis earlier, is they will be healthier in the long run. So that's kind of what I see the point of this slide.
Great, thank you. That's the last question. Oh, we've got one more here.
All right.
Virginia says our gluten group has often been asked about doctors to diagnose celiac disease. The doctors will do the endoscopic without a gluten challenge so often.
Interesting. Yeah, when I talk about the gluten challenge, I think that's the most useful diagnostic test because, people just look at me with tears in their eyes going, I don't think I can do that. And, some, like I said, 30% don't have any symptoms and, really don't have symptoms. But there are many people who just kind of understand how awful they feel when they eat gluten. So yes, there are many GI doctors, and even I ordering blood tests. I have patients who are already sort of or mostly gluten-free, and I'm just very clear with them that it might not be positive. Sometimes we still test it because I think like Anonymous had shared, sometimes we still test that blood work. It can still suggest if we are still getting gluten, but we don't know it. So there is some utility in it, but often those tests are negative. So again, if you're going to go through it's a medical procedure, an endoscopy, they put you to sleep, anesthesia, it's a real deal. It's worth it, to really know, but it can often be negative. So that's the debate that doctors have. We want a real test. We want to have, a proof saying you have this. I was trained with evidence-based medicine, and there is a role for it. But again, it's the art of medicine. We have to also respect patients and, the cost and the risk and I don't want to eat gluten for, 3 months before I go and have that done. And that's okay. It's just, we have to recognize that the test is not as good.
Dr. Kreizenbeck. Thank you so much for your time today. We will have the reconvene tomorrow, same time. We are going to send out another email with the code for those of you who needed a code to get in. The recordings will be available after tomorrow's session. So as soon as we can get them processed and up, you will receive an email with the information in it. So thank you all for attending, and we will see you tomorrow.